Hi, everyone, and thanks for watching this recorded presentation entitled Healthcare System Financing, What's COVID Got to Do with It? Brought to you by Springer Publishing Company and featuring Mr. Benjamin Goldsteen, one of the authors of the textbook Jonas's Introduction to the U.S. Healthcare System, now in its 9th edition. My name is David Diadana, and I am the senior editor responsible for the Public Health and Health Administration publishing programs here at Springer Publishing. For those who do not know much about Springer Publishing Company, we are an independent publisher known for innovative textbooks, professional references, and clinical products in the fields of nursing, behavioral and health sciences, and medicine. I'm delighted to introduce our presenter for this recorded event. Mr. Benjamin Goldsteen has 20 years of experience as an innovator in healthcare and life sciences organizations. While working at one of the largest consulting firms in the world, he led multiple strategy and performances improvement engagements for healthcare clients across the United States, from assessment through implementation. He is highly knowledgeable about all aspects of healthcare delivery and the policies that impact the healthcare system. He recently started a company focused on developing analytics products and services for health systems and is currently supporting COVID-19 vaccination efforts in underserved communities. And here's the agenda for this recorded session. Ben will be walking us through how the U.S. health system's response was financed and how it continues to be financed during the pandemic, the implications for future financing of the U.S. healthcare system, and using the frameworks and new COVID-19 eChapter from Jonas's Introduction to the U.S. healthcare system to understand the pandemic. And with that, I'm delighted to hand the reins over to Ben.
Hello, and again, thank you for joining the recording today. I'm going to speak in particular about the financing aspect of the healthcare system, and we'll talk in particular about how the financing of the healthcare system held up under COVID, which I think makes a good lens for understanding just how some of the things work and some of the challenges that it's been facing that were then exacerbated by COVID. If there's one thing we saw with COVID is that any sort of fractures or stresses in our system were just greatly magnified by COVID. And so what were problems that everyone knew about before just became much worse under COVID. And I think that was true of the financing of the healthcare system, in particular, the healthcare system and the financing of it. We were able to perhaps mitigate some of that just through an allocation of tremendous resources. In a crisis like COVID pandemic, you do, of course, whatever necessary to get through it as an existential threat. Nonetheless, I think that as we look to make a more sustainable healthcare system in the future, there are underlying challenges to the healthcare system that we should try to address. And first, we'll just have a brief overview of the healthcare system before we look at how it fared under COVID. And one of the things that most commonly seen in the healthcare system is just how significant it is to the U.S. economy as a percentage of the economy and how much we spend on healthcare in the U.S. And by any measure, spending in the U.S. on healthcare is much higher than anywhere else and is significant. Whether we look at it as a percentage of GDP, which has been most frequently done recently, we look at it as on a per person basis. We've looked at it, and benchmarked either of these against other countries, as well as what we spend on particular services and so forth of other similarly industrialized countries. In general, it is seen that the U.S. healthcare system is substantially more expensive than others in all respects. And although not a focus of this section, generally we don't see higher quality or better outcomes from the U.S. healthcare system than others. So it isn't that we're simply buying better healthcare, but rather we're just spending a lot more for healthcare that seems to be comparable to other industrialized nations. And perhaps in many cases, the US healthcare system shows up as underperforming the healthcare systems of other countries. And in a particular challenge also, I think, which always puts healthcare on the radar is just its significance of its growth. So although it's high, it continues to grow as a share of the economy, which then crowds out other, the ability for the economy to produce other types of goods and services. I think we'd all say that we want to make sure that we have the best healthcare that we can. But if we can get the same healthcare for less, and then we can allocate those resources to producing other goods and services, that would be beneficial. And those other services could be things that are also important to sustaining life, such as housing, food, and other types of necessary and critical things, infrastructure for travel, or transportation, and so forth. Within the spending on healthcare, hospital care is typically the single largest category. In the year that this was analyzed, which was approximately 2017, 33% of spending in the US was attributed to hospital care, hospitals and hospital-related care. An additional 20% was related to physician and clinical services, and then the rest broken up. We typically see things like prescription drugs, although very visible to a lot of people, is actually a much smaller percentage, oftentimes growing significantly, but overall it is typically the third or fourth category as far as the component of where money in the healthcare system is spent. And those numbers have been relatively constant over the years. If we look back to previous years, we typically see similar types of numbers, that hospital care is typically in the 30s, and it's typically the largest. And second is physician and other professional clinical services. And then the other categories do move around a bit, but typically in similar proportions. We haven't seen a dramatic change in those numbers. And then looking at the expenditure on healthcare along different dimension, which is that of just the diseases that we treat, we typically see the top 10, and on average, most of the spending goes for chronic diseases. And so although the television shows may, of course, present the rare diseases and the traumas and the accidents, those are a significant, but still a much smaller percentage of the healthcare system than the chronic diseases. A CDC estimate from a couple of years ago, it estimated that approximately 90% of healthcare expenditures were for essentially chronic diseases, the vast majority of which are preventable or treatable. And so you can see on this graph here, of which we have many more graphs in the book, but for this graph here that we pulled out, this is ordered in the sort of the frequency or occurrence of these diseases and then what spending. And so heart disease being the most common, and trauma was the second most common issue, and then mental disorders and so forth. But we actually spend a little bit less per case on those. And so the total spending is less in those. And actually, if we look at on the flip side, although hypertension was closer, not towards the top, because we do spend a lot of money on hypertension related diseases, the spending was higher. But again, trauma was, less than total spending. And as you can see, and mental disorder was one of the highest. And you see the other diseases are mostly chronic diseases. And of course, this predated COVID, and so you'll see infectious diseases close to the bottom of this top 10 list. I think that will probably change when the 2020 data becomes available. But historically, we have not infectious diseases have been well controlled in the U.S. and therefore is typically not close to the top one or two diseases by the amount of spending or frequency or similar. And of course, up till COVID, many infectious diseases are readily treatable with antibiotics and antivirals, the exception being HIV and a few other viruses. And of course, in 2020, COVID. The updated numbers will be available towards the end of 2021. And then we do expect, and of course, in the book, we always update with the latest data. So that will be shared in upcoming editions of the book. The other aspect of financing in the healthcare system is just the wide variation in utilization year to year. Unlike many other sort of life-sustaining things, healthcare is typically episodic, although many of the chronic diseases are ongoing. The very high spending tends to be episodic. And so what we typically see is a small proportion of the people have very high levels of spending. And then on the other hand, typically we see almost no spending in about 50% of the population, with some variations in between. And we also typically see, which is a little bit more detailed in the book, is that these typically don't persist year to year, although a sizable portion do. And I think the most recent numbers were in the 20s, were typically in the same quadrant that they were from the prior year into the coming year. The majority of people are not in the same category year to year, which is to say, if you're in the top 1% this year, you're unlikely to be in the top 1% next year. It's probably a significant episode of care, and that's not repeated year over year for the majority of people. But the flip side of that is that because it is very significant, and if you think about those numbers, they are more than the average annual income of the vast majority of Americans, it motivates the need for some sort of insurance. Very few people can afford those kinds of bills in any one year. And since they're typically not persisting year to year, we need some way to smooth those out, some sort of protection, which of course is insurance. And that's where the vast majority of funding for healthcare goes through the insurance system, whether government or private. And although, of course, most visible to people through their out-of-pocket expenses, which we've seen to become, again, more visible through cost sharing in recent years, actually the cost sharing percentages have been going down over time, as you can see in the right chart. And that's, of course, because historically, healthcare before Medicare, before Medicaid, and before some of the plans, a lot of people paid for their day-to-day medical expenses like they paid for other services, non-healthcare services, out of pocket. You paid for the doctor, you paid them in full based on that. And it's relative with the advent of insurance and so forth that those have started to pick up increasing components of the bill. And so on average, the out-of-pocket expenses have gone down as a percentage of the expenditures, even though we've seen more cost sharing in the insurance plans in the past few years. And of course, also part of that is that although some of that may be more, the cost sharing may have increased, the overall cost has increased oftentimes faster. And so again, the insurance picks up a greater proportion, even if the amount that impacts the average person and the average household feels greater. But this is how we've financed this, and the necessity, kind of motivated by the previous graph, of some sort of insurance mechanism, whether private or publicly funded. But actually how those funds flow from households, where of course we generate the resources to provide a healthcare system, as well as all the other aspects of the economy, is fairly complicated. As you saw, there's many different components of financing, many different types of payments, many different insurance programs. And as you can see in the right graph here, it gets even much more granular than was in the previous graph. In the US, we have carved out many different ways to pay providers or cover people through different programs. And as a result, it's never simple. And even the same one person covered under the one plan, if that plan, or one seeming plan, if that plan was actually managed by different employers, they might get slightly different benefits. And so many people would seem similarly situated can have different benefits. And even people that seem to have the same plan can get different benefits. But the left side shows how this sort of flows through. Employers in the US play a significant role in providing healthcare for households through essentially payroll deductions and other sort of offsets that they provide to sponsor insurance, which they manage more or less themselves to varying degrees. In some cases, they manage and take on the risk themselves, we typically see in larger employers. In other cases, they buy essentially more in a market where a managed care company assumes the risk and is essentially insuring on behalf of the employers, therefore accepting both the upsides and the downsides of managing that care. As I mentioned, the government and significant government programs. And I think in total, between Medicare, Medicaid, as well as the other types of programs, we see that actually the majority of funding for healthcare in the US comes through some sort of government program. And as I mentioned, although as a percentage is gone down, the various cost sharing arrangements that are associated with those plans, there's always that still remains a portion of the payments to healthcare providers that comes directly from the households through co-pays, co-insurance, and other types of cost sharing arrangements, which we do describe definitions of those in the book a little bit more clearly, more detailed. And the arrangements can differ very substantially. Those arrangements differ substantially in how they're structured, and in particular, what is the driver of the payments, which can then have significant influence on both consumer as well as the provider behavior. And we kind of talk about this as a framework in the book, but basically ranging from what we'd call so-called cost plus models to some sort of value and capitation type arrangements. In a cost plus model, essentially the actual cost of care in particular episodes, whether they be visits or longer hospital stays, is trying to be estimated, and then the person or then the provider is paid back essentially for what that cost of care is. And that was a more popular approach, especially for hospitals care in decades past, but we've moved more towards various fee-for-service and so-called prospective payment systems, which try to provide the provider what they should get for treating the disease or the situation that the patient is presented, but not directly related, not directly to their specific cost for that specific patient. And as even with challenges of those kinds of models and managing costs have come about, there's been a continued push, especially in recent years, to capitation and so-called value-based care models, value-based payment models. And again, the idea is to try to shift the conversation towards focusing providers on how to maximize the value and maximize the utilization and efficiency of use of resources in providing care. And that's become a much more significant model in recent years, but has been challenging to implement for both for the providers as well as for those contracting with providers, and certainly for individuals if they were to try to enter in such an arrangement. And so fee-for-service is the dominant model that is of how providers are paid in the U.S. healthcare system, although we are seeing a shift in the healthcare system and an emphasis more on value and shift to quality, paying based on quality metrics. Fee-for-service still underlines the majority of payments in the U.S. healthcare system. And the challenge with the fee-for-service model is that it essentially incentivizes providers to provide more services, volume or utilization of resources. It's not to say that people were deliberately ordering additional services, additional tests, additional drugs, simply that when they do, they receive more money, and when they don't, they receive less money. And so it seems that you were out of alignment in that. And if you think about if large organizations working from a performance improvement perspective, the challenge with such a model as well is that if you undertake a large initiative that requires significant investment, if that initiative actually reduces revenue, it's very hard to justify on a cost basis, a cost investment return. And so the shift, as we talk about, is to look at value-based models where, as providers become more efficient and use resources more efficiently to achieve a outcome for a patient, they would actually be incentivized further rather than less. But for the now, it's the fee-for-service model that we have. And as I say, it's with a shift maybe towards typically with quality metrics. And in this process, there's actually a very elaborate and process for payments that are based on standardized forms and claims, of course, are now processed digitally, and codes. And so one of the things we'll see is that for money to flow through this system, that you actually need codes. And we actually see that in the COVID. It was a rush to actually create these codes to make sure that providers could simply be paid for the COVID treatment. And the flip side of this also is a substantial amount of effort goes on both sides to both the payers as well as the providers to ensure that everything is coded accurately and optimally for the situation. For the payer side, they have to make sure that they're not being billed for things that were not appropriate or did not happen or should not be separately payable. And for providers, of course, they want to make sure that they get paid for everything they do and nothing was missed, since it's actually, if anything, less maybe the fee for service than it is fee for code. You get paid by the codes you put on the form in this model, less so than the actual services you provide. And so a substantial amount of effort goes into that. And when we look at a comparison of the US model with other countries, we see that the administrative costs in the US are much higher than other systems. And a lot of that can be traced back to efforts both on the payer side as well as the provider sides to manage the administrative work of billing for healthcare delivery. And another aspect of this is that as I mentioned, is the revenue that the providers receive also varies not just by the services they provide, but also, and the codes that they bill, but also who the payers are that are associated with those patients and the contracts that they have with them, and in particular the rates. And so this comes into an issue of essentially the same care provided to a Medicaid patient will be paid less than that provided to a Medicare patient. And typically that will be less than what that same hospital is provided to a patient that's covered by a so-called commercial or private insurance model, even though it would seem to be the same care and you would expect the same costs. And then the outcome of that is that hospitals that are in areas that essentially have more patients with those higher paying insurance typically have more revenue, again, independent of what the quality that they provide, and that they have more resources, therefore, to invest in further improving their situation or adding better amenities to the services, pianos in the lobby, as well as other types of, sort of luxuries beyond a standard bed or other type of service. And then providers, of course, in order to ensure that they are financially sustainable, work very hard to manage their costs. And that typically comes down oftentimes in minimizing their excess capacity and making sure that it's aligned with the day-to-day needs, as well as similarly both for labor and supply. And again, we'll see this come back when we talk about COVID, in that what you do to optimize your costs on a day-to-day and month-to-month and perhaps even year-to-year basis doesn't prepare you well for COVID and other sort of surge type situations where you need a tremendous amount of excess capacity to care for patients. And so as I talked about earlier, the healthcare system faced an unprecedented financial challenges under COVID. Perhaps the last time we had a pandemic of this nature was the early part of the 20th century, yet the healthcare system was nowhere near as developed as it is today. So this is the first time perhaps the modern healthcare system, as we know it, faced this kind of surge and financial pressures. And it had a dramatic impact on hospitals and their finances. A lot of hospitals have built business models that depend on a large number of high volume, high margin procedures, typically things such as knee implants, hip replacements, as well as various cardiac surgeries, as an example. Anything that was not considered emergent, that is to say life-threatening, was shut down in the early part of the pandemic, either by government or just by patients who were trying to avoid the healthcare system, while the healthcare system was trying to meet the demands of the patients who were coming down with COVID and filling the critical care units and other aspects of the hospital. But the flip side of this is while the hospitals may or may not have been busy, similarly with physician practices, those volumes, those high disappeared, and that revenue from that type of work also disappeared. And so the hospital wouldn't, of course, in the pandemic want to cut staff or cut any of its other expenses, yet their revenues would be substantially down. Some of this was backfilled with COVID patients who the healthcare system had to adapt to figure out how to pay for very quickly. But nonetheless, some health hospitals in the system suffered very dramatic drops in revenue during this, and were forced to the verge of bankruptcy. And some of the smaller hospitals were also forced to close. On the flip side, while revenue was dropping in many cases, expenses were going up quite a bit. Anybody in critical care was in high demand to support COVID patients, patients on ventilators, and so forth that require the highest level of training in their area. And in some cases, as there were imbalances in those and the needs for those people nationally, staff were being recruited nationally into hotspots like New York and other places to meet the sort of overwhelming demand on those healthcare systems, and paid so-called agency rates, which typically are many multiples of what a typical person in that role would make, just to keep their facilities going and to ensure they had whatever resources they could to care for their patients. And additionally, as mentioned earlier, there was a shortage of key supplies that were required, especially for infectious diseases like N95 masks, in the case of respiratory diseases, ventilators. And this led to bidding wars among providers for those resources, critically required to operate, and a limited supply. And so the prices of these items were bid up quite a bit. In some cases, the government stepped in, although not exclusively. And then that led to situations where, in fact, providers were bidding against the government and vice versa for this limited number of supplies, further pushing up the prices. And to adapt, and as the healthcare system does what it needs to do in order to care for the patients as best it can, but there are certain well-documented cases and featured in newspapers and whatever of healthcare staff wearing garbage bags or similar just to make it through with some level of protection. Not certainly the ideal from a clinical perspective, or they were re-wearing some of their, so in theory, disposable masks and gowns, again, just to make do and have some level of protection. But again, certainly not optimal for an infection control perspective. And so in this crisis, there was a couple of things. And again, remember, if the fee-for-service system, one of the things that essentially drives payment to hospitals are those codes. So one of the first things that happened was they had to create new codes for COVID. And at first they just said reuse the coronavirus codes, a generic coronavirus codes. But pretty quickly I realized that this was a new disease with new challenges. And this wasn't going to wait for the annual updates. And so then several days after that advice came out, a new advice came out of new codes that were created specifically for the SARS-CoV virus and COVID treatment, as well as other services related to that. and those were quickly standardized. So processes, again, there's a whole apparatus around billing within these healthcare systems, literally processing hundreds of billions, if not trillions of dollars every year. We're quickly updated to accept these new codes, to use these new codes, to identify situations where these codes were applicable, provide guidance on their use, and so forth. And this was done back in the early days in February and March. And so although perhaps not what we think of when we think of responding to COVID, in this system that had to be done in order to continue to flow money to the hospitals at the rates that would be needed to sustain those institutions. And also there's usually a typically multi-year regulatory process for determining the rates that are associated with various treatments. And again, not time in the case of COVID. So many of these steps were just bypassed and estimated. And again, that was what had to be done in this environment. And it's sort of an artifact of a fee-for-service system that you need some mechanism in place to do this. And you need a way to set prices even when nobody really knows what the right rate is at that moment. On the flip side, we also had to see, because people didn't know how these things would be affected, and the goal was not to distract organizations with rules around quality from caring for the emergent COVID patients. Some of the quality programs were suspended, or at least penalties related to them were suspended. In other cases, because the payers, there was a drop, as mentioned before, in many of those so-called elective procedures. Those are procedures that, although should be done, are not emergent. And so things like NIPs and NIP implants, knee implants, and hip replacements, the providers were down. In some cases, the payers stepped in and simply just advanced payments to hospitals. Similarly, the government advanced payments to hospitals just to help them sustain while the system transitions. And so probably following that and continuing and following that are reconciliation processes to figure out what's the right amount, and if there should be any returned, or if the hospitals get to keep that. And finally, one of the other things that happened that doesn't happen historically in the US healthcare system was direct investment and direction by the federal government around just the production of supplies and regular devices. We saw that with ventilators, where in some cases car manufacturers were commandeered to produce ventilators, and additionally anyone who could possibly produce masks, gowns, and similar was commandeered. And this extends to also other types of things. We see later with the vaccines, although the invention of the vaccine, the development of that particular set of proteins and other types of things was, of course, the invention. Simply scaling that up to support hundreds of millions and billions of doses globally required investment in things just like the kinds of glass that is used to store vaccines, and how to mass produce that in a way that would preserve the quality of the vaccine. And again, Defense Production Act and similar were used when necessary to do that, which again, historically has been unprecedented in healthcare, is that sort of direct intervention in the supply chain, at least in the US. And then on the payer side, what we saw was millions of uninsured people, or worries about millions of uninsured people avoiding the healthcare system due to the prohibitive cost when faced with the current rates that are charged for that care, avoiding that system, and therefore remaining in the community both untreated for their own sake, as well as a potential spreader of disease. And so a couple of things were done to address that. What we saw was essentially kind of a universal healthcare insurance for COVID, which is to say that anybody presenting at a hospital with COVID or similar, the hospital would be paid for that independent of that person's health insurance status. And in fact, in some cases, even if they were not a citizen or another way documented, just to ensure that no one would be turned away and no one would be returned to the community if they were infectious to others. And even for those who insured, we saw suspension or other waivers related to cost sharing for COVID-related treatments. Again, so that people wouldn't avoid the healthcare system when they need it. In many areas, if not all, testing was essentially made free. Although insurance might be billed, the idea was that individuals would not bear any out-of-pocket costs for anything related to testing. And that's also been true with vaccines, which again, were procured at the federal level for the US and distributed. And then various other mechanisms were used to pay for the services to actually administer those vaccines. Again, trying to eliminate any financial barrier to access, and to ensure that everybody could get vaccinated, initially tested and then vaccinated without consideration of financial impact to them. And in these cases, oftentimes FEMA grants or similar types of arrangements were used, which are essentially returned to a cost or cost plus basis. Those organizations that participated would essentially submit all the things they had to do that were attributable to this work, and they did what they needed to do, and they were reimbursed on this. With Hatch has both positive and negative things for controlling costs, but in this case, I think the goal was to ensure that we did whatever we needed to do to ensure that as many people were tested, the virus was controlled, and later people have been vaccinated. So in summary, we can see that a quite dramatic impact throughout all aspects of the system to ensure that it continued to operate while facing this crisis. Providers, although they bared significant increases in costs and drops in revenue, and this did leave some that were forced to suspend operations or close, various mechanisms were rushed in to try to keep them whole. This included payers, both government and private, advancing payments to providers, some of which was simply to avoid issues that would come up later with the so-called medical loss ratios, where if they didn't, they would have been penalized anyway. So they, if they did it earlier, it was a gesture of goodwill, and if it was done later, it probably would have perceived negatively, but would have been required nonetheless. Substantial is probably an understatement of the level of involvement in the federal government in ensuring the pieces of the healthcare system continue to operate during the pandemic. Unprecedented direct intervention in the medical supply chain, as well as a relaxation of many regulatory processes. I can speak to one hospital system or one state in which hospitals were basically said, just email us if you open up a new nursing unit. Just do whatever you need to do. Just email us when you do it. Historically, that would have been a 6-month process to open up a new nursing unit from a regulatory perspective, not to mention a construction perspective. The shift in operations during the pandemic was dramatic relative to what was seen pre-pandemic in almost every aspect of the system, both from a financial as well as regulatory perspective. For some patients, this actually increased access to the healthcare system because they, although it's typically only when they had COVID, they were able to gain access when they otherwise wouldn't have had access previously. On the flip side, what we will see going forward is an unclear impact of COVID, and as well as people avoiding the healthcare system. Another thing we know is that people with severe and chronic diseases avoided the healthcare system when it wasn't related to COVID, when at all possible. And as a result, we do know that some people, their chronic diseases may have been aggravated by this, and that there'll be long-term irreversible impacts to their health for that. And we don't know the impact of what that will be on the healthcare system, both from a demand and utilization perspective, as well as a financing and risk management perspective. And that will probably be borne by both private households as well as those who take on the risk of those patients and the cost of providing care to them. And all of this really motivates questions if this is really the right way to be financing our healthcare system. The system was, although adapted, it was quite dramatic. It was perilous for some organizations, and where they were forced out of business and capacity was reduced. In other cases, it was only by something equivalent to throwing money at it that we were able to keep some institutions and providers going. But it raises the question of the stability of the system when the revenue for these organizations can swing widely based on the mix of services they provide, even if they're still providing mix, but it happens to be in things that are perceived as being lower cost, when the cost of running these hospitals actually isn't changing, or in this case, was increasing dramatically. Another issue that it also raised is the appropriateness of a fee-for-service when you're trying to control pandemic and all the various cost-sharing arrangements. Those are designed to reduce utilization and as well keep people only using essentially what they perceive, keep limiting the access to the system and utilization of the system by putting financial payments related with each service. However, in a pandemic, we don't want anyone to not be treated and therefore potentially be infectious to others when they don't have access. And so although that was suspended in this situation, I think it raises questions of is fee-for-service the right way to be paying providers as well as throttling access to the healthcare system. And there's some positives as well as other questions that would raise about capitation and value-based payments systems and models. These systems probably would have created a more sustainable revenue stream for providers that were dealing with the healthcare crisis, but at the same time, of course, in some cases, their costs could be increasing where the capitation arrangements wouldn't be. And calculating quality metrics that might be used in value-based payment arrangements might be challenging when historical data would not be in any way applicable to what would be happening in the system for that year, and what would be the appropriate way to award or penalize hospitals for the quality of care patients received, when we have really no idea what the best treatments are for this novel disease and what best practice is in the beginning of it. And this will continue to see echoes of this as we go into coming years about how payments under those arrangements should be made, and how payers and as well, although payers may have essentially had lower costs over the year of 2020, are we going to see increased costs in 2021 and 2022 as people return to the healthcare system, perhaps with chronic conditions that have been aggravated by lack of healthcare in the previous years. Another thing also was in the system that it's historically rewards providers for efficiency through providing, in a fee-for-service model. There is no incentive to maintain various reserves and stockpiles of supplies, nor to keep staff that might be necessary for surge capacity. The goal is always to essentially have the minimum capacity in order to provide the services that organization needs on a day-to-day or month-to-month, and possibly 1 year over the next basis. However, in the case of a pandemic where demand is skyrockets, this sort of model doesn't work. Hospitals in the past oftentimes maintain large stockpiles of these sort of emergency supplies. But in recent years, the pressure was to reduce those because they were just sitting there, and it was increasing cost for the hospitals to maintain these large stockpiles. I know one hospital, for example, that had only 6 months prior to COVID had finally, at the recommendation of a consultant, had reduced their stockpiles of things like N95 masks, only to then be caught short and scrambling to get more N95 masks when New York became a hotspot in March of 2020. And this is a challenge both for this and other types of mass casualty events of how this should be paid, because it's very difficult to pay for those types of surge capacity out of operating expenses. Yet we do, I think, as a country and for the healthcare system to have this capacity when we need it. And then finally, it raised implications of the uninsured and undocumented. Although they were covered in the pandemic, they aren't normally cared for. And as we look forward to, or not look forward to, but we anticipate contagious diseases in the future, are we essentially creating systemic challenges for ourselves by not being able to see these patients early, and then only when the such diseases appear in those who happen to be insured or in other ways covered using the healthcare system. And as well, creating makeshift solutions for covering those patients when we are in a pandemic situation.
Thanks, Ben. As a reminder to our audience, the 9th edition of Jonas's Introduction to the U.S. Healthcare System, published in May of 2020, a new eChapter entitled The U.S. Healthcare System Responds to the COVID-19 Pandemic, will be available online to all qualified instructors and anyone who purchases a copy of the textbook. And here is a list of other teaching resources available with the 9th edition. So thank you everyone for watching this recorded presentation, and we hope you enjoyed it. Please feel free to visit us at www.springerpub.com/Goldsteen for more information about the 9th edition of Jonas's Introduction to the U.S. Healthcare System, including the new annual update chapter on the COVID-19 pandemic and the effects on the U.S. health system. Please also feel free to send any questions or comments through the email provided here on the next slide. We greatly appreciate any feedback you have, and we look forward to having you again as an audience member soon. Be safe and well.